Good evening and welcome to the Importance of Anaemia in Women's Health scientific webinar sponsored by Radiometer and HemaQ. My name is Danielle Brown and I'm the HemaQ Product Manager for Radiometer Pacific, and I wanted to thank everyone for joining our webinar today. You would have seen from the short video just now that if you have any questions, just pop them in the question manager and we'll get them as we have time at the end of the session. If we don't get to answering all the questions, you can contact us afterwards via our appreciation for attending email. There will also be a poll after the Professor's presentation and we would love you to all participate. As Professor Richards was travelling internationally so close to the webinar date, we thought to err on the side of caution and pre-record his presentation. He is of course here with us live and ready for the poll and the question and answers at the end. So now I would like to introduce you all to Professor Toby Richards. Mr. Toby Richards is a Professor of Surgery, Head of Division of Surgery and Director of the Clinical Trials Unit at the University of Western Australia. He is an Honorary Professor of Anaesthesia at Monash University and Honorary Professor at the Institute of Clinical Trials and Methodology at University College London. Professor Richards specialises in clinical trials and translational research and has been doing so for 20 years with a focus on anaemia. And so now I introduce Professor Toby Richards.
Good evening. My name's Toby Richards and I'm the Professor of Surgery in Western Australia. I've done a lot of work over the last 20 years looking at the problem of iron deficiency and anaemia in surgery. But about 10 years ago, I switched a lot of my work across to women's health, because after all, women are the most common people to suffer with iron deficiency and anemia, and I'll explain why in the next 20 minutes. I work with a variety of organisations, charities, industry, etc. in disease promotion and research trials. I've run several research trials in this area. Now, this is data from the Gates Foundation, and it illustrates the global prevalence of anemia. At any point in time, about 1 in 5 people in the world are suffering from anemia. And if you're a woman, 1 in 3 women will have anemia in their lifetime. The commonest cause, as seen in green here, is iron deficiency. And if you add that to menstrual loss in purple, that represents 3 out of 4 causes of anemia worldwide, or at any point in time, about 1 billion people, predominantly women. Now, how is iron absorbed in the body? At any point in time, for the sake of argument, you've got about 4,000 milligrams of iron in your body. 2,500 milligrams of that is sitting in your red cells. So iron makes up the core of hemoglobin that makes up your red cell. You have about 1,000 milligrams in reserve, and that's stored in the liver in a protein called ferritin. Now, I liken ferritin to the biscuit tin. If iron is your biscuit, the ferritin is your biscuit tin. It's essentially just a tin that stores the iron. The rest of it, about 500 milligrams, is in the muscle, and it's also in the nervous system because it's very important for immune function and neurotransmission. And every day, your body gets rid of about 50 mils of old red blood cells, cells that are about 3 months old. These are filtered by the spleen, and because the red cell membrane becomes fragile, they're broken down, you pee out the debris, but the iron is recycled through the macrophages and ferritin. And it's very, very good at doing this. You only need about 3 milligrams of iron at any point in time every day. So even though you've got 4,000 milligrams in your body, only 1% is needed to top up the stores because the body is so efficient at recycling iron. And there's only 2 ways you can really get iron deficient. You simply do not take in enough iron, i.e. your diet is poor, or you lose iron, and the commonest cause of iron deficiency is blood loss, either gastrointestinal or women and heavy menstrual cycles. And I'm going to come on to this. But let's look at it on a case-by-case basis. This could be anyone's daughter. She's at university. She's 21 years old and she's spending a lot of time sleeping, not paying attention. Her grades are falling, and I'm sure everybody knows this story. But what you've got here is a set of blood results that are within the normal ranges. And a key aspect of this talk is to break down the dogma of normality and ultimately to treat women the same as men. So bear with me while I'll explain this. I've got 3 slides on science. Now, in 1959, the World Health Organization looked at the distribution of hemoglobin in men and women. And they decided that men would have a hemoglobin cutoff of 13 and women of 12. However, let me put this to you. When you're defining a normal range, don't you want a normal population? So if 1 in 10 women at any point in time are iron deficient, why are you including those people in the normal population? So in this study of 35,000 people, they went through all the blood results for women and they excluded those with iron deficiency. Guess what? The normal distribution in pink shifts 1 gram per deciliter to the right. So if you exclude those with the disease in the population, then men and women should be treated exactly the same. And they should have exactly the same hemoglobin. They are, after all, exactly the same Homo sapiens. So the panel of 9 men in 1959 who decided these levels perhaps should revisit these numbers. And indeed they are. The World Health Organization has anemia as a target, and they are currently reviewing the definitions of anemia for men and women. Now, when you look at causality, iron deficiency, again, here I'm going to challenge the dogma of normality. In this study of 7,500 people, what they did is they took people in a large population study called NAMES in America. And they said, right, okay, as someone's ferritin level, i.e. that protein, the biscuit tin that represents iron stores in the body, at what point do hematological values change? And the answer was a ferritin of 25. And if you look at lab values, which can be done on 200 people in the local area, no differentiation of those who are ill, which is 1 in 10. A lab value is just a median and 2 standard deviations based on a sample of 200 people within your laboratory or around the area. It's a laboratory number. It's not a disease-defining number. The WHO defines iron deficiency as 15, but data from this study shows that if you're a little bit low on iron with a ferritin of 25, your hematological values start changing. And this is very important because let's just say you've got a ferritin of 20 and your ability for your bone marrow to make red blood cells is reduced by 10%. So if your red blood cell lasts 3 months and each 3-month period you produce 10% less, it might actually take 2 or 3 years for you to become anemic. However, if you've got a ferritin level of 5, i.e. 0 iron, then you might only be producing 20% of the red blood cells each month, in which case you will simply become anemic in about 3 to 6 months' time. So once you're iron deficient, anemia, that's just a matter of time. And so if you're only mildly iron deficient, it might take ages for you to become anemic. But the symptoms develop earlier. The symptoms are of iron deficiency, and I will talk to you about that soon. And what I'm trying to do is to get you to think about men and women being equal, and iron deficiency is the disease, not anemia. If you look at this study, and this is data from the Zimmerman group out of Switzerland. In this study, they take fit and healthy women, 600 of them, and they feed them radio-labeled iron, so perfectly stable. And the question is, how much iron is absorbed in the body? And the answer is your iron absorption rate is completely static to a ferritin of 50. It's about 5% of your daily input, or 2 to 3 milligrams per day, just enough to recover what you lose on a day-to-day basis. Between 50 and 30, your iron absorption rate improves a little bit, so to about 4 milligrams a day. But below 30, and particularly below 20, you start seeing an exponential rise in the absorption rate of iron. And what this suggests to me is that the optimal level for ferritin is about 50. Between 50 and 30, you can probably eat your way out of iron deficiency with a change in diet, or if you have heavy menstrual bleeding, reducing the loss. However, below 30, you will need to supplement because you simply cannot eat that amount of iron on a daily basis, and I'll come on to that. So the message of what I'm saying here is, if you regard anemia and iron deficiency a bit like the petrol in your car, you go and fill up your tank, in which case you have a normal full tank of petrol. When you start coming depleted, the little light comes on. You know, you're on your reserve tank, but the car only stops working when you have absolutely nothing left in the car at all. So iron deficiency happens earlier, and anemia is just one of the consequences. A different way of looking at this is if you look at kidney disease, CKD4 is dialysis, but you've got stage 1, stage 2, stage 3, and they come before that. And anemia and iron deficiency, I would say, should be ranked the same: stage 1, stage 2, stage 3, stage 4. And anemia is failure of the bone marrow to work. Iron deficiency may have been going on for many months before that. So why is this relevant? Well, we do a lot of work on social media. And nowadays, people go on Dr. Google to get their diagnosis. They go on Dr. Facebook to find out how to treat it. So we asked in 6 different Facebook forums, what are the symptoms of iron deficiency that you experienced? And the list was over 70 long, and I'll come on to that. But we had 10,000 responses in 24 hours to this poll. And the most striking thing was that women suffered for an average of 8 years before they received appropriate treatment. And when you look at it and you look at the raft of symptoms, yeah, fatigue and tiredness is there. But the next bunch of symptoms are shortness of breath or air hunger, as illustrated by the woman bending over, palpitations and chest pain. These are cardiac symptoms. And if you look and see what happens to these women, it often is the case that they end up in the emergency department being investigated by the cardiologists, when in fact they just have iron deficiency. But a really big set of symptoms are neurological: headaches, brain fog, depression, anxiety. And the meme you see in the top corner is the most common meme to describe iron deficiency in women's health. Other symptoms when you've got profound iron deficiency are pica, eating ice, eating dust, paper, etc. Complete non-food items. And if you've got a ferritin less than 8, this is real. These women, when you ask them, they won't volunteer it. But when you say, you know, with a ferritin of 6, many people are eating really strange things, you'll be astonished at the response. Restless leg syndrome is very common with a ferritin less than 4. And the one thing that many people don't realize is that iron deficiency is the commonest cause of hair loss in women and of brittle hair. Particularly in the postpartum, when you get a massive drop in your ferritin level, perhaps due to the pregnancy in the last trimester, or blood loss at the time of surgery. This can precipitate the hair follicles moving from a static phase or a dormant phase into a shedding phase. And in that situation, you need to be aggressively treated, aiming for a ferritin over 50, possibly over 80, to restore your hair stores. But let's look at another common cause. This is a woman who presented in extremis. She had severe iron deficiency anemia at the age of 45. She felt tired, exhausted. She'd been on and off iron tablets, just like all the other women on Facebook, for the best part of a decade. And she was so fed up. Now, what's going on here? heavy menstrual bleeding is incredibly common. It affects a minimum of 1 in 10. But I would suggest it affects about half of all women during their lifetime. And so this is where we've been doing a lot of work in Western Australia and also throughout Europe. We've developed a questionnaire. And that questionnaire is, who are you? And then, do you suffer one of the following symptoms? Do you need to double protect? Do you have to get up at night time? Do you pass clots? Do you use more than 12 types of protection during the course of a cycle? And do you have fear of flooding or accidents? 2 out of 5 of those symptoms indicate heavy menstrual bleeding. And that's very common. And how common is it? Well, here we are doing a spot questionnaire. So we go to a conference, and we've done this in shopping malls, we've done it at sporting events, and we ask those questions of heavy menstrual bleeding. And then we do a HemaQ. Here, the 201, but more recently, the 801 machine, which has been really reliable. And essentially, if you've got a hemoglobin less than 13 on a finger prick, you're 1 in 4 chance to be iron deficient. Got a hemoglobin less than 12, and you trigger 2 of the points on the questionnaire, 50% of women will have a ferritin less than 15. And in doing these surveys, we identified that heavy menstrual bleeding predicts those people to be anemic and predicts those people to be iron deficient. And if I had my way, these machines and this questionnaire would be in chemists throughout the country. The treatment of heavy menstrual bleeding is very simple. It starts with raising the awareness and, again, challenging the dogma of normality. And there are very simple treatments like tranexamic acid, etc. But let me put this into perspective. If you have 2 of those symptoms, need to double protect, more than 12 episodes of protection, etc., you're losing 80 mils of blood every cycle. Now, that might not seem very much, but it's a litre a year. So if you're a small 60 kilo individual, you're losing 1/3 of your blood circulation every year. It's hardly surprising you run into trouble. And let me give you the numbers for that. The circulating blood volume for someone who's 65 kilos will be just under 4 litres. And if menstrual loss is heavy menstrual bleeding, you're looking at that litre a year, or 25% of their circulating volume every year. So it's the same as major surgery or 2 hip replacements every year. And that's 20% of the entire population of women, and probably 1 in half of all women in their lifetime. And how do you treat this? Well, they can eat a horse. But like I said, you can't really eat your way out of iron deficiency. You could have 200 tablets of iron, and iron is best given as 200 milligrams once a day. So you're looking at a minimum of 9 months of treatment. Or you can have blood transfusion, but there's no iron in blood, or there's very little. Or you can have intravenous iron therapy. And in Australia, we use more intravenous iron than any other country in the world. And the benefit of intravenous iron therapy is you can now safely deliver this as 1 infusion quite easily over approximately 30 minutes or so. And 1 iron infusion is the equivalent to about 6 months of iron tablets. It doesn't have the side effects of iron tablets of constipation and diarrhea, and has become normalized in Australia. But in the rest of the world, this is still relatively a novel treatment. And what happens, here's this lady as I treated her over a 5-year period. She presented profoundly iron deficient and anemic. And what you can see along the bottom represents 5 years. And at 45 years old, she underwent an iron infusion every 1 to 2 years because she was perfectly adept and quite happy to manage her heavy menstrual bleeding, as she had been doing all her life. She did have an endometrial ablation, which helped a little bit, but essentially nature took its course at the menopause, so she avoided the need for a hysterectomy. But let me give you another area that I've been doing a lot of work in. This is a 37-year-old lady that, again, might have fairly normal looking blood results. And this lady came to my clinic and said, when I'm running a marathon, what I find is when I'm doing the last 6 kilometers, I feel really tired. And that wasn't to me something that rang alarm bells. I thought, well, I'm running a marathon, I'm a bit knackered in the last 20 kilometers, not alone 6. But this one is not normal. This is Elspeth. She's the 2 times winner of the Marathon des Sables, which is the Trans-Sahara endurance race. They run 60 to 80 kilometers every day for 6 days. And actually the race was undertaken at the beginning of October. So why is this relevant to her more than anyone else? You would have thought, hang on, she's a top athlete. She won't have periods because top athletes don't have periods. Well, let me hit you with all your preconceptions again about how wrong you are. There are several things about athletes. As I mentioned, you only need about 2 to 3 milligrams of iron a day in the body because you recycle it so well. There's actually only 2 ways you can lose iron: blood, and top athletes have exactly the same instance of heavy menstrual bleeding and normal periods as normal women doing parkrun or walking down the road. We looked at the London Marathon and we looked at the UK Olympic team, and I can assure you they have exactly the same problems with their menstrual cycle as anyone else walking down the street. Amenorrhea only comes in when your body mass drops below 6% fat, and in the majority of athletes that's not the case. But the second way you lose iron is through sweat. The skin is incredibly rich in iron. It has a ferritin of about 300, and that's why in iron deficiency women lose their hair, because the skin content of iron goes down. You lose approximately 1 milligram of iron every hour of exercise because most people sweat 1 to 2 liters per hour. So if you're doing an endurance race, you're losing 3 to 4 milligrams. But the other aspect is when you do endurance exercise, you shut your kidneys down, you get acute kidney injury. So this is starting to become a bit like a chronic disease. But the key aspect here is when your legs hurt after a long run, it's nothing to do with lactic acid. That's just magazine talk. If you've got high lactic acid, you can breathe that off in a couple of minutes. It's not a problem. What happens is the small fibers in your muscles, when they contract and expand, you get little tears there indicated by these lines. And any form of tear causes inflammation. Inflammation disrupts the normal pathway of iron absorption in the body. It activates a protein called hepcidin, which shuts down iron transport, which means iron is kept in the biscuit tin, the lid's firmly put on the biscuit tin, and you shut down the transport of iron around the body. And this is indicative of what happens in disease as well. You would have heard about iron deficiency and anemia in heart failure patients, in Crohn's and colitis patients. It's inflammation disrupting normal iron stores. Hepcidin goes up, it blocks absorption from the gut. Iron is sequestered into ferritin, the lid's put on, and so the bone marrow becomes starved of iron, and consequently, eventually, you develop anemia or chronic disease. And so in the set of athletes, women who are athletes are normal women. They have normal periods unless they're very extreme weight loss, and that's really only during competition. They sweat a lot, they get tissue damage and inflammation, and female athletes need about 3 times as much iron as normal. Male athletes about twice as normal, but male athletes very rarely become iron deficient. But what happens now with this iron? We've talked about hemoglobin, but all hemoglobin is it's a cell. It trundles up to the lungs, grabs the oxygen, there's my oxygen, and it goes back to the cells and gives the oxygen to the cells. It's just a delivery system. But in the cells, That's where oxygen and glucose is metabolized to produce energy, ATP, and that's aerobic metabolism. Aerobic metabolism, i.e. the generation of energy, occurs in the mitochondria of all the cells. And the mitochondria are the little nuclear powerhouses. Every single enzyme involved in aerobic metabolism has iron in it. So if you don't have iron, you are not able to have aerobic metabolism. And I'll highlight that for you here. We took a group of mice and we randomized them to a normal diet and an iron deficiency diet. And we exercised them on the treadmill. They're remarkably fast, these little critters. They can go at about 4 to 5 kilometers an hour for about 20 minutes. As you can see, these are English mice. Had they been Australian mice, there'd be little numbers on their back and bedding slips in place. But there we go. And so what did we find? If you feed mice an iron deficient diet, then they become iron deficient before they become anemic. And in the black line, you have a normal mouse trundling along on the treadmill 3 times a week for about 20 minutes. But the iron deficient mice become exhausted after 10 to 12 minutes. And this was reproduced on many occasions by one of my PhD students. We then give the mice an iron infusion. So we inject them with intravenous iron, and it does exactly what it says it's going to do. The iron increases and your ferritin increases. And within 3 days, not 2 weeks, 3 days, these mice have normal exercise capacity and they're running around just as much as the other mice who are not iron deficient. Now, hemoglobin takes a minimum of a week, ideally 3 weeks to be made. So this is an effect on aerobic metabolism and muscle metabolism that's completely independent of the anemia. And this you can see when you look at the molecular analysis of the mitochondrial proteins, the cytochromes, which contain iron. And you can see very quickly, in a matter of hours, that the function of these enzymes is dramatically increased. And this is work by Anna Butcher. Also, if you compare different types of muscles, so those muscles which like the soleus calf muscle, which are highly aerobic, they have dramatically reduced performance compared to the more anaerobic muscles such as the quadriceps. And this is work by Katerina. How does this translate to humans? Here's me behaving like a mouse on a treadmill. I'm being filmed, so I'm trying really hard not to look as exhausted as I really was. But hey, here's my heart rate. It's just topping 170, and I've got a couple of minutes to go. What we do is we exercise athletes to complete exhaustion. So we took a group of female athletes. We identified that they're iron deficient, and would like to say thanks to the Vegan Marathon Runners Club in London. They were our #1 source of patients. And we put them on the treadmill. And you put them on the treadmill at their exercise capacity, which is around about 11 to 13 kilometers an hour. And every minute that treadmill goes up 1%, and ultimately they get spat out of the back. And so they exercise to their absolute limits. We then give them intravenous iron and we repeat the experiments. What we found in a cohort of 25 women was that their quality of life significantly improved. So this is their fatigue score, measured in 2 different ways. But what we also found was that their VO2 max improved by approximately 4 to 5%. Now, this is monumental to athletes. This is the equivalent of 3 months high-intensity training in 2 weeks. So the message from my presentation here is that we have used finger prick hemoglobin measurements combined with a questionnaire to screen for iron deficiency in the community. We found it effective when we can identify 50% of those people with iron deficiency. Because iron deficiency is a disease, anemia is just one of the consequences. How did we do this? we treated men and women equally, and we made the cutoff for anemia 13 in both groups, in both sexes. Why is it relevant? Because iron deficiency impacts muscle function and also cerebral function. It's the commonest cause of depression and anxiety in middle-aged women. Athletes have very high demands of iron, and it can become a functional iron deficiency where the lid is on the biscuit tin. So although you've got iron, you are actually behaving like you're iron deficient. And in this setting, we suggest that the laboratory markers for ferritin are moved to 30 and to about 100 in those with chronic disease. So food for thought, and I have a few questions for you. Thank you very much. Great. Good morning, good evening, everyone. And I hope you enjoyed that presentation, which was aimed to summarize the situation of iron deficiency in women's health, how it is very much a hidden epidemic, not just iron deficiency, but also heavy menstrual bleeding. So we've got a series of questions here, and we'd like you to vote online. The first question is, what is heavy menstrual bleeding? Symptoms are listed there in the poll. So all you got to do, I think, is click on them. So heavy menstrual bleeding is not a medical condition. It is actually a symptom defined and described by patients. It can be categorized by a series of symptoms. And actually, for the purpose of time, it can be any two of those 5 symptoms would indicate that a woman has got heavy menstrual bleeding. And that's the need to double protect, to have to get up at night time, change the protection more than 12 times in the cycle, fear of accidents of flooding, or the passage of clots. Just 2 of those symptoms would indicate that a woman has got heavy menstrual bleeding. So we'll just move on, for the purposes of time, on to the next poll. And following on from that stream, what do you think the amount of blood loss during a normal period for a woman is if they have heavy menstrual bleeding? So if a woman has heavy menstrual bleeding, how much blood do you think they're losing every month? So we'll give it another 20 seconds. And heavy menstrual bleeding is something that is normalized in society. There's a lack of awareness of what is normal and what is abnormal. And it's only by raising awareness of this will people realize where the problems arise from. And the answer here is medically put at 80 mils per cycle. And that adds up to 1 liter of blood loss a year over 12 months. The impact of heavy menstrual bleeding is it's the commonest cause of iron deficiency in the world. And so we measure iron deficiency by the serum protein ferritin, which is also likened to the biscuit tin. It's what holds the iron within it. Now, in the body, at what point does serum ferritin trigger an increased iron absorption from the gut? So at what point does the body start recognizing that you're low on iron and needs to absorb more from the diet? What serum ferritin would indicate that? People are going quiet on this. So it's a serum ferritin of less than 50. And this is important because if you look at normal blood results, then these may indicate the reference ranges. And reference ranges just reflect the normal and standard deviation
of a local laboratory. However, a ferritin less than 50 triggers increased iron absorption from the gut. Now, at what point do you think that a ferritin less than 50, at what point does low ferritin cause a change in your red blood cell metabolism? So you start increasing iron from the gut when the ferritin drops below 50, but at what point, when does ferritin get so low that it actually causes the red cells to have an impact on their metabolism and their shape? So we'll just show those results now. What are people coming up with? Okay, so it's actually a ferritin less than 30, well, specifically 25, sorry, it falls between 30 and 20. At that point, you'll start seeing red cell indices starting to change. And the final question is, at what point of iron deficiency does physical fitness get impacted on in female and also male athletes? So at what point, when you become iron deficient, defined by a ferritin, at what level does physical performance get affected? So the common misconception is that a ferritin less than 15 is iron deficiency. And in some reference labs, they even put it down to a ferritin of 12. It's actually a ferritin less than 20 starts to impact physical performance. So to summarize, iron deficiency starts to become a problem to the body at a ferritin less than 50. At a ferritin less than 30, your red cell indices are changed and you start to become anemic. But at a ferritin less than 20, you start to get physical symptoms of iron deficiency, leading to fatigue and tiredness and reduced exercise performance. And we'll close there, and I'll happy to take any questions at all.
Thank you very much for that, Professor. That was a wonderful and insightful presentation. And thanks for participating in the poll, everyone. Now we have had some questions come through, but before I go to them, I would like to introduce two ladies via audio, Charlotta Blomstrand and Annika Eriksson. Charlotta is the Global Hematology Manager for HemaQ in Sweden, and Annika is the Clinical and Scientific Affairs Manager for HemaQ in Sweden. They have joined us today in the event that there are questions we should point towards them. So welcome, Charlotta and Annika. And now I will go to the first questions that we have had come through. Okay, so the first one, Professor, I'd probably be best for you to answer this one. It seems like a great idea for all women to be screened for anemia. Do you know where they can have the test done?
So I do think that all women should be screened for iron deficiency, and screening for anemia is part of that. So if you are anemic, the commonest cause is iron deficiency. But I do think teenagers and then those people at risk should be assessed with a formal full blood count and a ferritin level through their GP. So if you suffer with heavy menstrual bleeding or you've got likely symptoms, recent mother, then you should be tested accordingly. We gave some results of some surveys that we've been using the finger prick HemaQ. And this is a finger prick device that you get a drop of blood. And my understanding is that you can actually get tests for that in the chemist now, the same way that you can get tested for diabetes in the chemist.
Okay, good. And this next question actually feeds quite well into that one. How often do you think women should be screened?
So It's easier if you've had a history of iron deficiency. If you've had a history of iron deficiency characterized by a ferritin less than 30, then you should supplement with oral iron for a minimum of 3 months, and then retest your bloods 3 months after that, and then probably 6 months, and then annually, and then twice a year. I do think that most women probably should be screened as a teenager. Then again, when they're going to university as part of health checks, and probably every 5 years in the asymptomatic population.
Okay, excellent. Probably the next one. Are there any differences in the measuring techniques that are available for screening for anemia?
In screening for anemia, probably the main one is a normal blood draw, and those go to a central laboratory. In the most part, those are pretty standardized. What you can now get is you can get a finger prick test, which we've been doing a lot of in the community, which is, as I mentioned, just like a glucose test, and a drop of blood can give you a fairly accurate result for your hemoglobin. For iron, there are no finger prick results for iron. If you want to get your iron level checked, you need to have a formal blood test looking for ferritin. There are companies selling finger pricks out there, but we've looked at that in detail and we haven't found them to be very accurate.
Okay. You mentioned that Australia has the highest rate of iron infusions. Do you know what other countries utilize this treatment?
Yeah, so Australia is quite a long way ahead in this, and about 8 years ago, iron infusions got listed on the MBS coding. So this meant that general practitioners could provide intravenous iron free of charge to their patients. There's really only one other country in the world that uses that volume of iron, and that's Switzerland. Aside from that, Europe is probably an order of magnitude, i.e. tenfold less likely to provide iron infusions. Very few places throughout Europe that provide iron infusions in primary care. And the situation is far worse in the States, where healthcare is a private system, and it can cost an awful lot of money to get an iron infusion in the States. It's actually easier pre-COVID for people to fly from the States to the UK and get an iron infusion in the UK.
Okay. The next one that's come up, it's especially difficult for teenagers that have just started menstruating to know what is actually heavy menstrual bleeding. Do you feel the education is there enough for these young girls?
No, absolutely not. I do a lot of work with the International Society of Obstetrics and Gynecology, and heavy menstrual bleeding is a symptom. So it's something that impacts the mental or physical welfare of a woman. It's incredibly normalized in society. I run an iron clinic, and we see women coming through who won't go out of doors for 2 days, are using 60 maxi tampons per cycle. It's quite astonishing what they put up with, and they had no idea that it was abnormal. And this gets pushed down to teenagers as well. And we've even had teenagers who give up university places because they're simply unable to cope with their menstrual cycle at university. Now, some of that may be abnormal uterine function, but at the same time, it could actually be a disorder of blood clotting, such as von Willebrand's disease or platelet dysfunction. And those are things that can be addressed relatively easily. But there's a real problem about normalizing both symptoms of iron deficiency and symptoms of heavy menstrual bleeding, and we really need to raise awareness about women's health in both regards.
Yep, agreed. The next one, what is the difference between iron deficiency and anemia?
Yeah, so look, this is a really common misconception. There's a belief amongst doctors and amongst patients that you have to be anemic to be iron deficient. That's not the case. So if you are iron deficient, let's say your ferritin drops below 30, you may not be providing enough iron, enough building blocks to the bone marrow to make red blood cells. And at relatively low levels of, say, 30 to 20, your bone marrow may be able to kick out 80, 90% of the red cells that you need. So it might take many years to become anemic. But during that time period, you're iron deficient. If you're severely iron deficient, so ferritin less than 10, then your bone marrow may not be working at all, in which case you just become anemic faster. Anemia really should be regarded as a symptom or a consequence of iron deficiency. It's iron deficiency that's the underlying disease. Anemia is just one of the consequences.
Okay, good. What's the situation for vegetarians? Should they be more concerned about being iron deficient?
Yeah, no, I think that's incredibly important amongst teenagers as well. I have no issues with being a vegetarian, but if you are a vegetarian, because humans are obligate carnivores, we rely on meat in our diet. Vegetarians need to seek out the correct foodstuffs. And unfortunately, Popeye was wrong. Leafy greens may have loads of iron in them, but that it's so tightly bound to the cellulose and to the structure of the plant, even with a bit of vitamin C, virtually none of it is absorbed. To put it into perspective, if you want to have the same iron absorption as a chicken breast or say a 100-gram steak, you need to eat about 2 kilos of spinach every day. That's 2 big bin bags. It's impossible. What's good is pulses, soya, lentils, things like that. But unfortunately, if you're a vegetarian and you're iron deficient, you cannot eat your way out of iron deficiency. It's impossible. There's just not enough iron. So you need to supplement, and you need iron tablets, or if they fail, you need an iron infusion for treatment.
The next question I was going to ask, I don't know if there's anything you need to add to it. I think it's been mostly answered, but the next question I was going to ask was the best way to increase iron through diet?
So the key is the recognition, and if you are a vegetarian, unfortunately you won't. It's soya, lentil, pulses. Now, if you're not a vegetarian, there's this sort of strange belief that we've all got to rush out and gnaw on raw liver. I mean, it's revolting. Who eats the stuff? Maybe 1 or 2 people, but the concept is that there's a separate metabolic pathway for iron absorption from any form of meat. Yes, red meat's a little bit better than chicken and fish, but any form of meat has about a 10 times better absorption pathway than plant-based food. The other thing to consider is iron supplementation. This is traditionally 45 to 65 milligrams of elemental iron a day, and that's the same as a 200 milligram iron sulfate tablet. 1 tablet a day is just fine, but if you do get side effects from that, then you're looking at taking 1 tablet on alternative days. I could probably follow that up with, there's a bit of a misconception about the use of vitamin C. You actually get a fair amount of vitamin C in a day-to-day diet. So supplementing with vitamin C on top of oral iron doesn't make a lot of difference, to be honest. It's only valuable for non-heme iron. But new clinical trials have shown no real benefit from the addition of vitamin C to iron supplementation.
Okay. What is your thoughts on using non-invasive testing for hemoglobin?
We tried that. We've been doing a lot of screening in the community, and unfortunately, the non-invasive testing goes on your fingernail, and we found about 2 out of 3. Well, firstly, if you've got nail varnish on, it doesn't work, and yeah, we just didn't find it very effective to work. We did a lot of the screening in the UK, and I think a lot of people's fingers were just too cold to get accurate measurements, so we abandoned that.
Okay.
So there's a few people asking about intramuscular iron. That's a treatment that was around probably 20 years ago. There's really no role for it in modern society. The doses are really low and the absorption rate's not great. The only place I found that still uses it is some of the islands in the Caribbean that you can only get to by plane, where the use of intravenous iron is not possible.
Okay. Next one. Following my 9 months of iron tablets that have been ineffective, resulting in low saturation percentage and low hemoglobin, would you recommend transfusion as an option?
Yes, absolutely. So taking oral iron, 1 tablet a day for 3 months, should see a significant rise in your serum ferritin. You really want to be aiming for a ferritin heading towards 30, and then you want to continue taking the oral iron for another 3 months, aiming to get a ferritin of about 50. So you really need about 6 months of oral iron. So if after 3 months your ferritin level is sort of wobbling along at 20, then you really need to cut to the chase and get an iron infusion. That's failure of oral iron, which happens in about 1 in 4 people. And so an iron infusion is indicated for failure of oral iron, and failure is really ferritin less than 30 at 3 months, and not normalized within 6 months.
Okay. Heavy menstrual bleeding. What is the ramping rate of hemoglobin per month when following iron oral supplementation?
Yeah, so look, when you've got heavy menstrual bleeding and you're iron deficient, you've got 2 problems at hand. One, you've got to treat the iron deficiency, and you should get onto that quickly. And 2, you've got to stop the loss. So depending on how bad the heavy menstrual bleeding is, oral iron will give you about 200 milligrams of iron per calendar month. And if you got to the point you're anemic, you're at least 1,000 milligrams behind. So you're at least 5 to 6 months behind. For heavy menstrual bleeding, the first line treatment is to use tranexamic acid. This is not an acid, it's an amino acid like lysine, and it binds to the breakdown, the products that break down blood clots. So it stabilizes blood clotting. It doesn't cause clots, it stabilizes and reduces blood loss by about 1/3. It's dirt cheap, it's got no side effects, and it's readily available. So that's the first line treatment. The second thing to do then is to speak to your doctor about hormonal therapies, or depending on age, other options as well. But you have to stop the loss. Otherwise, it's like pouring hot water into a bathtub when the plug's been taken out. You've got to treat both angles.
Yeah. Okay. Is there much difference between iron supplements themselves, such as ferrogradimate and maltopher? I'm not sure if I'm pronouncing that last one correctly.
Look, yeah. The answer is not really, to be honest. There's a shed loads of marketing out there on different types of iron supplementation. They're all essentially iron salts. Some come bound with vitamin C. The key is to look on the back of the packet and look at the dosing, because whilst it might say 300 milligrams and 200 milligrams on the front, that's the amount of the iron salt. What you want to look at is the amount of elemental iron, and that needs to be 45 to 65 milligrams and that will be on the ingredients on the back. There are new oral irons coming out. They're being trialed by the Gates Foundation in Bangladesh and Malawi at the moment, and hopefully we'll get the results of those soon. But essentially, it really is what you get from the chemist. You don't need to buy the expensive stuff. The cheap stuff's just as good.
Okay.
And watch out for the advertising on the liquid iron and the stomach-friendly irons. What you find out when you read the back of them is they've basically got virtually no iron in them. So always read the label.
Always pays to read the label, I agree, yes. We've probably got time for this one last question. My daughter has suffered from chronic iron deficiency anemia since she was 5 years old. She has had so many tests and a couple of blood transfusions and many iron infusions. They haven't found the cause yet, and she's now 13 years old. Do you know any other causes for this?
Yeah, well, yeah, it's a difficult one because there'll be a long... So I think this highlights a key point. If someone has a set of blood results that reveal a low ferritin, low transferrin saturation, and anemia, then the answer is very clear that that individual has iron deficiency. If the results are relatively normal, let's say a ferritin of 25, normal hemoglobin, TSATs and they're hovering on the normality, the key is to go back through the history. And you do have to go back and look through the history in detail and look at trends. Many people live with iron deficiency for up to a decade. The commonest causes we've talked about are nutritional, which are failure of lack of iron in the diet, or excess loss, which can be pregnancy or heavy menstrual bleeding. Iron demand is also significantly higher during growth spurts of young children. And then you get into areas of malabsorption, which can be celiac disease or other gastrointestinal diseases such as ulcerative colitis. There are some rare diseases that are non-anemic iron deficiency, and that's a disruption in the hepcidin transport mechanism. And in those settings, and particularly something like this, these people need to be under a specialist pediatric hematologist. And it's a matter of going through things there and looking at the genetic profiling, etc. from there.
Excellent. Thank you so much, Professor. That's probably all that we actually have time for today. So a big, big thank you to you, Professor. That was just an excellent presentation and discussion. And thank you to Charlotte and Annika also. And thank you for attending, everyone. And just a reminder, we will send a thank you email with a link to the on-demand replay. And you can also request extra information by contacting Radiometer, the distributors of HemaQ in Australia and New Zealand. Thank you again to Professor Toby Richards, and good morning, good afternoon, and good evening.